Great. So hello and welcome to this ARMA webinar, which is about integrating physical and mental health for people with MSK conditions. We put this webinar on because depression and anxiety are so common amongst people with MSK conditions. There's an increasing awareness of the links between physical and mental health, but there's still significant numbers of people who are not even being asked about their mental health. And I think one of the reasons for that is that physical health professionals can be reluctant to raise mental health issues because they're worried that there won't actually be the support in place to meet any issues that they identify. So ARMA has mental health as one of our priority areas for this year. And this webinar is just one part of what we will be doing throughout the year to focus on that topic. So I'm really pleased that we have today Dr. Lindsay Ip, who's a clinical psychologist at King's Health Partners. I heard her present a few months ago on the work that she does to integrate physical and mental health services. And although her work is not focused on MSK conditions, when I heard about it, I thought, well, that approach would work equally well in an MSK clinic. So I'm now going to hand over to Lindsay to explain what she does. And it will be great to hear at the end whether you think this might apply in areas that you work in. Lindsay.
Thank you very much, Sue, and hello everybody. Welcome to this webinar, and thank you for your time. So I'm very excited today to share with you a service that I've been leading in the past 2 years. And like Sue said, I'm very excited also to hear your feedback afterwards about whether you think this model can be applied to your work setting. So the service that I lead is called 3 Dimensions for Long-Term Conditions, and some of you might guess right that the 3 dimensions actually stand for the biopsychosocial model, really. So we are a service that is initially funded by the Health Foundation for 2 years, and also a bit of money from Guy's and St. Thomas's charity. And we, you see all these logos on this first slide because it's really come about because of a partnership between a mental health trust, SLAM, and 2 acute trusts, so King's College Hospital and Guy's and St. Thomas's, as well as King's College London for the research part. So it's quite a lot of sort of coordination to really bring about the service, and we're also very grateful that we got to recognize for innovation in mental health category of the HSJ award last year. So so today I'll be just sharing with you sort of why we think this model is necessary, what exactly we did, and also share some of the challenges in implementing the services and how we try to overcome it. So it'd be sort of less clinical in nature, but more focused on service development. So why are we doing this in the first place? I'm sure most of you would know the huge overlap between mental and physical health. We know that at least 1 in 3 people with long-term health conditions also have a mental health condition, primarily anxiety and depression. And when they have both, mental and physical health condition, all the outcomes are worse. It really affects the morbidity and mortality. They also use emergency services 2 to 3 times more. And on top of that, if you add the sort of social deprivation, everything is just worse. And this actually accounts for somewhere between 8 to 13 billion pounds of NHS spending. So arguably, integrating mental and physical health is one of the best value propositions. And looking specifically in more sort of the condition that you more relevant to you in MSK, this is from NHS Public Health England. We know that over 24% on average of patients with long-term MSK problem also report feeling depressed and anxious. And for the younger population, that percentage can go up to about 37%. So I assume that this is also very, very relevant to you. There's also plenty of evidence to show that pain, which is prevalent in MSK, is better explained by sort of a holistic biopsychosocial model. So in addition to the neurophysiology, the emotions and the social element and cultural element also plays a role in both the perception, the experience, the maintenance of pain. And so it just makes scientific sense to treat patients as a whole. So going back to the 3DLC service, what we focus on is integrated heart failure service and the respiratory team. So 3DLC consists of a small team of clinicians. So it's myself, a clinical psychologist. We have a consultant liaison psychiatrist and a social support worker, which we contract from Thames-Reach. And together we try to integrate psychosocial care into heart failure and respiratory conditions across these two trusts, Guy's and St Thomas's and King's College Hospital, which serves the Lambeth and Southwark borough. Altogether, we work across five different teams. So we also have a small portion that is for treatment-resistant hypertension. And we're actually a scale-up project from a previously successful model called 3 Dimensions for Diabetes. So the challenge for us is we are hoping to see if we can use the same level of resources. So they also have a team of 3 people in psychiatry, psychology, and social support. But we're trying to see if that can be spread out across multiple long-term conditions rather than just diabetes in one team. So that was our initial kind of challenge. So where do we start? We really took our time to step by step, trying to get to know the people we're serving, and we see them as both the patients and the medical teams. So we did a bunch of scoping exercise, focus groups, interviewing both patients and doctors, nurses, physios, and sort of come up with some of the main things and values that people have in improving care for patients. We also found out that among our nurses and physios, we did a staff survey, and actually about 85% of them reported that they would encounter patients with mental health needs at least on a weekly basis. And at least half of those said that they encounter those on a daily basis. So this is actually really relevant to our teams, and yet they don't really have much support or training around how to deal with these patients' mental health issues. And oftentimes the most complex patients do have mental health needs or behavioral, emotional needs that get in the way of them being able to manage their condition. So for example, they might be too depressed to come to rehab, they might be too anxious to take all the medications. So this is a real need for them. And before 3DLC, so before we started the service, when we talked to most of our providers, the way they handled it was, once they identified someone needs mental health service, they would usually tell the GP, the patient's GP about it, and then the GP would do something about it. So that's easily can add on a few more months of wait time. But what we're trying to do is to shortcut that and equip our medical teams to refer to signpost people to proper mental health care. So after some scoping exercises, sitting in on consultations and interviewing people, we've designed a service that consists of these 3 main components. The first is developing a screening and referral pathway for psychosocial needs. So we really want this to be part of routine care, and this to be sort of a systemic change. So we were able to partner with another project called Impots, which basically provides the electronic support. So they give us this iPads, which consists of brief questionnaires about patients' anxiety, depression, and the quality of life questionnaires that they would fill out in their waiting room. And then the results would be automatically uploaded to the clinicians or the doctors or the nurses sort of electronic patient records, and they would be notified about what the results mean and also what the pathway is. So what's the action point? Would that be referring to services in the community or referring to us, for example? So that's one of a big thing we're implementing, the screening and referral pathway, and it has been in about 14 outpatient clinics now over the across the 2 conditions. So that's one thing. The idea is we really want our healthcare professionals to see the patient's mental health score as another vital sign. So when patients come to the doctor's office and have their blood pressure taken, around the same time they'll be asked about their mood as well, and to treat that as just a normal part, a routine part of care. And the second thing is with workforce development. So a huge chunk of our time is also devoted in education and training. So there's a series of education and training for our medical teams that is bespoke to their needs. So each team actually may be starting off on a different level of understanding or readiness in terms of working with patients' mental health needs. So we really try to be flexible and accommodate that. And a lot of it is done by us plugging into the existing CPDs or their multidisciplinary team meetings. But we also have standalone workshops, full-day workshops, 1-hour workshops, but also 15-minute sort of spiel within the MDM. So there's a variety of formats that we try to deliver that. Another thing we do was regular group supervision, especially for the nurses, which kind of focuses on discussing cases in more details, so managing the behavioral systemic issues around the patient's needs. And then lastly, we also do some clinical work. We follow a stepped care approach. So myself and my colleague, the psychiatrist, will see the most complex patients with complex mental health needs that also interacts with the management of the physical health condition. But we have a way of sort of screening them out. So in the referral pathway, people will have a way to sort of triage, identify what level of care needs the patient have. So some of you may be familiar with the stepped care model that sort of NICE has set out, and there's sort of 4 different levels of need, with level 4 being the most complex and level 1 being not so complex. So level 1 would be cases that are mild, maybe actually quite normal adjustment issues that our patients will encounter, and hopefully those would be, in the ideal scenario, we would be able to upskill our medical teams to have the confidence and the skill to manage those sort of common adjustment issues, emotional adjustment issues, whether that is through some guided self-help or some sort of brief CBT interventions that they can do. And then for level 2, those would be sort of more persistent but subclinical, mild to moderate anxiety, depression, and those would usually be directed to services like IAPT in the community or the wellbeing hubs. And then for levels 3 and 4, those would come to us. For those with even higher risk, we can then also direct them to our community mental health services. So those are the sort of 3 main components of our service. And for each of these components, we try it in a sort of paced manner. We do these PDSA cycles and continuously try to improve. It's really an iterative process, and we really try to listen and learn from our colleagues' sort of feedback. So in about 2 years, we were able to screen more than 2,000 patients. It was not a very smooth process, but we managed to do that. And continuously, we're still monitoring it and trying to improve and make things smoother. Over 800 patients have been referred to us, and we assess about 2/3 of those patients. No, actually a bit more. I think about 80% of those patients were assessed by us, and the rest we were able to offer advice or refer on. And in terms of direct training, we trained more than 700 staff, and those include both our immediate medical teams in cardiology and respiratory, and also we did some GP trainings, and also a wider network of district nurses, and in conferences and all that. So yes, we try to, although we mainly focus on secondary care, we really do try to reach out to across primary, community, and secondary care. We also surveyed our staff to see how well, how much impact we have on how they work with patients. So we did a survey baselined and also in about 9 months. And we found that now over 95% of our staff thinks that it's part of their job to actually consider patients' psychosocial needs. And then 2.5 times more staff say that they are confident in identifying the right course of action for their patients' psychosocial needs. So our service is also evaluated independently by the University of York, and there's both a quantitative component and a qualitative component. For the quantitative evaluation, we look at both physical functioning sort of measures, and those are disease-specific outcome measures. So, for example, for COPD, there's the CAT, so COPD assessment test. With heart failure, there's the heart failure Minnesota Living with Heart Failure scale. I'm sure there will be something for MSK if you decided to do something similar.
There is indeed, yes.
And then we also looked at depression and anxiety scores. We used the PHQ-9 and the GAT-7, which is commonly used across primary and secondary care. We also look at quality of life, the EQ-5D, which most health economists would use for the economic evaluation. We do have a health economist doing that economic evaluation for us as well. And lastly, we also look at service utilization, both A&E, hospital admission, and outpatient and community visits to see whether there are any changes to more appropriate levels of utilization. So we've had 179 patients consented for the research, and we do have some preliminary results, which we should do an analysis, but we're still waiting for the independent party to give us the full analysis. But what we've had so far that I can share with you is quite encouraging, that we find significant reduction in depression and anxiety scores, as well as all those disease-specific measures for symptom burden for quality of life. And we're still waiting for our economic analysis, but that's good reason to believe that there is some significant reduction in that. In terms of our qualitative research findings, so there is a qualitative researcher also from the University of York who did I think 3 rounds of interviews, both for our patient groups and our staff as well. And these are some of the themes that she found so far. So there's definitely a consensus that psychosocial awareness is being raised in the teams, that most of the staff feel like we have a good working relationship, and that actually we were able to change the way that care is being delivered. Patients also reported improved physical functioning. So this is usually what they care most about, whether they're able to do a bit more the things that matter to them, like looking after their grandkids, or just going out to the park a bit more. So there's a good number of patients being interviewed who reported an improvement in that, as well as an improved mood and quality of life, and also feeling very grateful that they're being treated as a whole person, because actually I think more than half of our patients have 2 or more long-term conditions, and it's a very common a concern that they feel that care is quite fragmented, and they go to a lot of appointments, but don't have really a sense of coherence or sometimes proper understanding about how all the connections, how all their medical conditions affect them. So actually our service provides a space for them to feel, to explore these concerns and get more of a sense of coherence and being treated as a whole person. So that is something that they said that's really valuable. So I've just kind of briefly talked about what we did and some of the things we were able to accomplish, but it hasn't always been an easy journey, and we do have some hiccups, a lot of uncertainties, and and obstacles along the way that I can share with you. So I suppose with most sort of innovation projects or change projects in a large organization, broadly speaking, these are the cultural, political, and architectural or sort of structural elements in an organization can be quite sort of powerful. They all interrelate, and they can work together to either hinder innovation, hinder change, or enable them. So sort of on a broad level, these are some of the things that I can highlight. And more specifically, for 3DLC, these are also a few things that we notice. So in terms of sort of systemic level things, because we're working across 3 large NHS trusts, there are definitely some organizational boundaries. They might do things a bit differently. We have to use different documentation systems. So mental health, so SLUM, so mental health trusts have their own documentation system, and then each trust have their own. So oftentimes for each patient, we'll have to do double documentation. It's not the most efficient, but that's sort of what's needed for now. There is also, in terms of how organizational boundaries affect sustainability. So we are sort of in the process of, because our 2 years have run out, and we are in the process of building a business case to make this post and the service sustainable. But because we're working with 2 different directorates and across 2 big trusts, instead of having one conversation, one kind of business planning meeting, we need to have 4, and to get them to also agree. So things can be delayed just because of the complexity of dealing with different teams. And each trust also have different policies around the business cycles and planning. So one trust may have more levels of approval you need to get through to get your business case, to get the post substantive, and the other may be slightly different process. So that can be a bit tricky. And in fact, I've started off with so 2 other colleagues, a project manager and a psychiatrist, who has already left because not everyone can tolerate the risk of uncertainty. Like when it takes a bit of time to confirm the post, it's not uncommon for people to leave the post, and that could, you can lose momentum from that. I just happen to be a bit more positive and risk tolerance. But luckily, fortunately enough, I have some new colleagues that I'm working very well with now. So we'll see what happens. We should know soon whether our post will become substantive. But yes, so that I can see that could be quite an obstacle for any sort of innovation projects if the planning is not done right, because then it will become sort of pop-up projects, and you sort of lose the momentum. So in addition to systemic issues, actually the details also really matter. And that was kind of one of the surprising elements. So clinic space is really lacking, as well as administrative support, and it's just, these things actually couldn't be taken for granted. So if you're thinking of applying for a grant to do something similar, just to keep those in mind, to negotiate with people to make sure that there's enough space and admin support, because that can actually create a lot of inefficiencies if it's not sort of planned ahead. And also because we are kind of, again, working across 2 trusts, we have to be very flexible and actually travel between sites quite a bit. So for myself, for example, I need to travel at least between sites at least twice a week. And that's because we're trying to work around the multidisciplinary team meetings. We are compared to the whole team, we're small, so we can't really change someone's meeting, but working around it can sometimes be tough. And when you're trying to sort of divide up the work, for example, with the psychiatrist and myself, and take turns going to meetings, you end up you have less workload, but you also have less time for the 3DLC team itself to bond. So we just have to be more intentional about creating that the cohesion internally within our small team, as well as developing relationship with a wider medical team. And then clinically as well, the population that we are seeing, so the COPD and heart failure population, they're really ill, right? They're very complex most of the time. And so DNA rates can be quite high. This is not just specific to our service, actually, and the chest clinic as well. They do report that DNA rates aren't great. A lot of them are quite fragile as well. And when the weather is a bit warmer, like last year, it was really warm, you get more cancellations. When it's cold, you get cancellations as well. So so that's just something we notice, and we are working. We're trying to also look more closer into that to see what the main problems are, and there's a number of reasons. I think, in addition to the social circumstance or the physical illness, sometimes they're in and out of the hospital a lot, and that's some of those are inevitable. But we're also trying to look at whether they really got buy-in initially. Do they really want to come, or is it really mainly because of the physical limitations? And try to be flexible to work around that. And then lastly, cultural aspects. I think that's the essence of changes. We really want to change the whole culture of care and how patients are being seen and being taken care of. And although most of our medical staff, or actually all of them, would agree that it's important to integrate mental health into this long-term conditions treatment. No one denies that, but the level of ownership is quite varied across different teams. So for some teams, it's the lead consultant would be very enthusiastic. It's considered something very sort of respected and cool to advocate for, and for other teams, not so much. There might also be other competing priorities. So one of the teams that we work with, they were also undergoing the integration project in terms of sort of integrating primary care, community care, secondary care, and we are just one part of this integration project. So just competing for time and resources and attention sometimes isn't easy. For some teams, certain sort of doctors may think that yes, this is important, but it's someone else's job. Maybe the nurses can do it, but not me, kind of sort of thing. So those are some of the common sort of challenges. Stigma is another thing, although I think we did a pretty good job in really reducing that. But initially, there might be a lot of concerns about asking about mental health, opening a can of worms, thinking that is completely out of the scope. We've had some comments from certain cardiologists before, thinking that if they ask for patients' anxiety, depression, they're becoming a generalist. So these are some of the things that we try to work through. And stigma also happens, other than in our medical professionals, patients as well. So for some patients, maybe even hearing the word psychologist or psychiatrist can trigger some negative reaction, whereas others may see it as a luxury. So I just have to be sort of sensitive in how we introduce, how we ask our medical staff to introduce us as well. So how do we break these barriers? So I want to sort of go on a slight tangent about culture. So as I mentioned, I think ultimately we're trying to change a culture. And you probably have heard of this phrase that culture eats strategy for lunch. So there's this quote. Oops. So basically this analogy is it's like an iceberg, and strategy is oftentimes what you see as the tip of the iceberg, things that are on surface, on above water, and a lot of senior managers focus on that. All these sort of charts and strategic plans, and those are important as a guide, but a lot of times I think what determines whether change happens or how quickly it happens is the thing that is under the surface, the cultural elements. So just want to maybe talk a little bit more about culture change. And this is one framework to kind of look at culture. So basically looking at it in three different levels. Artifacts are sort of things that are tangible, that you can see. So there are routines, habits, structures, where things are located even, and symbols, and there are repositories of meaning. And oftentimes a change in artifacts over time with consistency can produce a change in how people think and their basic assumptions about things. But these are things that are more tangible. And then there are espoused values. So there are usually important starting points. Most hospitals or companies have espoused values like patient-centeredness, collaboration, that sort of thing. And it's important, but it's not enough to just broadcast these values when we talk about change. And then on the deeper level, there's assumptions. So these are deep-seated beliefs that sometimes are not articulated, but they can be actually the most important things that drive change, and they can serve as leverage points in an organization. So a lot of times, I think we try to shape culture change with values, but it's not enough. So sometimes, it's really important that we talk about, shared values and try to motivate people from the values. And in the ideal scenario, if people are very mindful and reflect on whether their action and the decisions are consistent with their values, that could work. But oftentimes we find that that's actually not sufficient, especially when those artifacts are not aligned with the values. So the things that are tangible that you see are not aligned with the values. And so something, as through reflection, what we also try to be mindful of is looking around and see what are some of the symbols, what are things that are tangible, what values are they actually reflecting, are they really consistent with what we say we believe, and actually changing those artifacts sometimes can be more powerful over time. So having that in mind and sort of coming back to what we did to try to overcome these barriers, I think there's a few main areas. So definitely, I think at the end of the day, people make change, and people constitute culture. So building relationships is really important on all levels. We try to be as visible and try to be sort of more part of the team by being proactive in attending the multidisciplinary team meetings every week. We really try our best to advocate for a space in their clinic. So I think co-located care is really helpful. A lot of the informal communication happens there. For the patients as well, it's very stigma reducing when they go to the same clinic rather than going to a separate mental health hospital. They are more receptive to working with us. So these really do help with building relationships and also reducing stigma. And then also, when we talk about relationship, to focus on both internally as a team within 3DLC, because like I mentioned before, we can be quite spread out. Maybe we see each other once or twice a week. So being very intentional, we did some reflective practice every month to just talk about how we are, how we're doing, how we feel about our impact, how we change things, obstacles, and support each other. And after all, within 3DLC, we're also a multidisciplinary team, trying to change another multidisciplinary team. So I think modeling that so collaborative culture within the team is quite important. And then, of course, also thinking about our relationships with each of the medical teams, and then even wider relationships with our community partners, because we don't want to be sort of a siloed service. We want to be plugged into the bigger system and other existing services and create that sort of interdependency and collaboration as well. And then, of course, relationships with our upper management, getting sort of support from our chief executives, those could be very helpful for sustainability as well. So relationships in all levels, and being patient focused. So ultimately, that's why we're all here. And routine screening and joint appointments are things that can reflect this value of being patient focused. When I talk about routine screening, so again, sort of going back to the analogy of the vital sign. When patients see that both the physical and the mental health condition is being assessed together, as they might feel more considered as a whole person. I think it's not uncommon for some healthcare providers to be a bit hesitant and think that some patients will mind, but actually when we do it, majority of patients actually are grateful for that, and they don't mind being asked how they've been feeling. Joint appointments are also done both at home. So we offer home visits as much as we can. We can't do it regularly for a course of treatment, but we usually try to do home assessments if the patient has problems with mobility. We also sometimes join our doctors and nurses at the ward or in outpatient clinics, and it's really helpful way to learn from each other. There's a lot of shared learning happening there, and patient feels like they are also being taken care of by a coordinated team. We discuss cases in our multidisciplinary team meetings, and we try to be flexible in our care delivery. So like I mentioned, occasionally doing home visits, sometimes doing therapy over the phone as well. Yeah, I think that could be further explored. I think there's some limitations to that because we're spread out across a few teams, but we try as much as we can. And sort of along the lines of flexibility, in addition to offer that to our patients, we also find that it's important to be flexible in our education and training approaches. So, for example, within our MDMs, the multidisciplinary team meetings, probably all we have is 15 minutes to do our education. And so I would have to try to kind of make something that is usually, let's say, motivational interviewing, something that I can do as a training for one day, to cut it down to 15 minutes for some of the cardiologists. And just having to be flexible with that and not too hung up on, that it needing to be a certain style and format. We just basically take every opportunity, even though it's not ideal or not complete, just believing that there is still value and impact, and being able to provide these bespoke training in the format that they can really digest in. And then lastly, enablers. So what are some of the things that are on the outside that helps us continue with this change initiative? So we're very fortunate to be part of a mind and body program, which is really an umbrella term, but it's one of the unique selling points of King's Health Partners, our academic health science center. And they're a team of people that kind of connects similar initiatives and really advocates for us, spreads the word, and do a number of supportive things. And so through the Mind and Body program, so 3DLC is considered a flagship project of Mind and Body program, we're able to get sort of high-level support, which definitely helps with sustainability. And also, building relationships with our community partners can be very helpful. NICE guidelines also is actually in support with what we're doing. So using that and spreading that as much as possible. For example, in heart failure, it is actually within the NICE guidelines to encourage providers to screen for depression in every heart failure patient. And then last but not least, having champions at every level is very important, not just physician champions, but actually our frontline staff as well. So, for example, one of the obstacles that we encounter when we try to implement routine screening is not having the administrator or the clinic nurse to consistently give out the iPads to patients. That is usually the weakest link. So it's not whether the clinic leads or the physician agrees to do that. It's the frontline person, because they are so overwhelmed with other administrative responsibilities. And so I think getting their buy-in, to not forgetting that they also need to be informed of the bigger picture, and having a sense of mission of why they're doing it, rather than seeing it as just another thing that they're being asked to do. It's just being piled up to their to-do list. So yes, champions is really important. And within the Mind and Body program, we do have a Mind and Body Champions Network that basically are for any healthcare providers in Southeast London who believe in integration of mental and physical health. And they meet regularly. There are networking events, there are free training events, staff wellbeing events, and we try to create a network of champions to support this initiative. So it's not just for 3DLC, but it's a wider movement of integrating mental and physical health care. So yes, we try to tap into that resource as well. And you're all welcome to join, by the way. Okay, so just some examples of how we were able to work together as an integrated team. This is a time when I was doing a podcast with our heart failure team. So we have a geriatrician, we have that's focused on heart failure. We have myself, a pharmacist, and a nurse specialist. And together we're talking about how we work together to treat elderly patients with heart failure, which is a very nice experience, and also shows the importance of having representation in your team as they go out and tell others and other generalists about how we do how we offer care. Like I mentioned, we are also very mindful about creating systems change. We don't want to be just a siloed service. So when we're designing our referral pathway, we engage with services like IABT, the Wellbeing Hub, and other charities to be plugged in the system, and we have cross referrals as well. We also try to spread our model and our learnings in different places. So these are examples of conferences, associations, mediums where we try to spread our learning. Or the more people adopt this model or this principles of working together, the better it is and the more sustainable we can be. We have also contributed to a massive open online course on integrated ways of working, treating people with both mental and physical health needs. And you're all welcome to join that as well. I'll give you more information at the end. So just to summarize some of the main reflections, I think the most important of element in successful integration is being seen as part of the same team, and also for the team to have ownership of the management of psychosocial issues. So some of the indicators of that is if they are actually doing a biopsychosocial assessment for all of the patients. So an example in one of our teams is that the nurse actually changed their clinic letters to include the social element as a section, and psychological section would include the PHQ and get 7 scores. So this is just a way to make it routine, a psychosocial element to be a routine part of care. We have sort of joint treatment plans. and then also being able to see the screening as another vital sign, like I mentioned before. And then last but not least, I think, and it's something that we're continually trying to think about, we don't have all the answers yet, but it's also how we motivate leaders to advocate for psychosocial integration. So again, on the cognitive level, everyone understands why, but in addition to that, I think it's helpful to sort of think about how does integration effort make them feel, like how being an advocate would make them feel and make them look. Is it a cool thing within their specialty? Because we do notice that in some specialties, maybe it's more so than in others. So why is that? And we're trying to explore what can actually make this more motivating, more incentivizing. Are the objective sort of incentive systems aligned as well? So I think one of the challenges is that even in our economic analysis, if we're able to prove that we are able to reduce the cost of healthcare by reducing bed days or admissions, that would show our kind of value. So under a sort of value-based healthcare system, that pretty much makes sense. But in reality, the services, a large part of their revenue is still generated by activity. So we don't actually, compared to the doctors, we don't generate as much income, but our value is mostly in cost savings, but that's not always as apparent. So just kind of thinking about how we can better communicate that. And also aligning the payment model so that it would make more sense. And then lastly, I think it's also helpful to think about whether there's sort of equality among the professions as we sort of strive towards this ideal of parity of esteem, where mental health should be seen as important as physical healthcare. Underneath that, are professionals being treated as equal in a way, or is it quite hierarchical? Because I think the hierarchy sometimes can get in the way, and we can have very different roles, but are they seen as important? Is there enough, for example, mental health professional represented in senior management? And all that. So I think those are just important questions to think about, as I think those are some of the things that can affect how well we integrate and how effective and how quickly we can do that. So those are some of my main reflections and insights. And I want to end by just showing you a brief video of our patients and what they think about our service. So these are patients with multiple long-term conditions who's gone through 3DLC. So I just want to invite you, if you're interested, to go on our website. If you're interested to be a mind and body champion, you can be from any specialty, but if you believe in integration of mental physical health care and want to learn more and connect with other people who to also believe that, then please do join us. And there's also a free course that you can attend as part of, actually, whether you're a champion or not, you can attend that free course. So yes, that is it for today from me. I'd love to hear any questions or comments. Thank you very much for your time.
Thank you very much. That was brilliant and packed presentation. Can you see the question that we have that has already come in? If you want to just summarize that question and respond to it. And I would invite people on the line, if you would like to post questions, or in the chat box, let us know if you think something like this would be useful in your area, or if there's anything that you're going to do, having heard what Lindsay's had to say.
Okay, so I see two questions in the Q&A box. Actually, one of them is not really a question. The other one is about, given the number of people in age ranges 25 to 55 and possible links with pain, what is the scope to take a more holistic, community-based approach? What about where there are medically unexplained symptoms, especially where symptoms may cross over MSK, gynae, gastro, neurological, etc. So yes, so what we do is also in the community, but maybe we have less sort of capacity to physically go to the community, as in do too many home visits, that sort of thing. But we do work with physios and nurses who are community-based. So, for example, I offer group supervision to nurses on a monthly basis. They also have, most of the teams have a community MDM, as they call it, so monthly, mainly focused on community nurses and how they work. So our supervision includes talking about more complex cases, how to manage, let's say, family dynamics that may get in the way of people's self-management, and also other mental health conditions. And so that's sort of an indirect way we're working with teams that are community-based. Medically symptoms are also something we see as part of it, in addition to anxiety and depression. And often with MUS, we also not just directly work with the patient, but work with the whole team to manage the patient. So because a lot of times it requires being a unified front, it requires a structured approach as a team. So the communication as a whole team is very important, and we support how to actually, let's say, deliver messages to the patient and structure treatment.
So then there's been a question about putting the web link up again. Yes, you will get an email from us afterwards, and we will include that link in the email, so you will all have access to that without having to watch the whole thing through again. And then somebody's asked a question in the chat box, which is about, do you need formal consent from patients for service evaluation?
So for service evaluation, no. For research, yes. So the independent research that the University of York is doing for us, for those parts of that 179 patients that we use, those require consent, and we just basically built it in the iPad. So when they do the routine screening, there's just another question asking them to opt in for research. But the research element is over now, and we continue to do that as part of service evaluation, and we do not need separate consent.
Okay, and then we've also had a question, someone who'd like to know, are we able to get in touch with you personally about trying to integrate this into our care? Now, I know some of our webinar presenters are happy to have their contact details shared, in which case we'll put it in the email, and some are not, in which case we won't. But if you're happy for us to put your contact details in the email, we will do that.
Yeah, sure, no problem. I'm happy to do that.
Okay, brilliant. Well, thank you very much, Lindsay, for that presentation and for taking the questions. Thank you to everybody who has joined. As I say, you will get an email from us afterwards. This is also part of a whole load of different things that we're doing about mental health and MSK. So do look out for the report of our recent roundtable on mental health and for other activities throughout the year. But I'd just like to end by thanking Lindsay very much for a really useful and thorough presentation, and I'm sure that there will be people picking this up and doing similar things in musculoskeletal in the musculoskeletal field. So thank you very much.
You're very welcome. Thank you. All right. Bye-bye. Have a good weekend.